Good morning. Bonjour, mesdames et messieurs. Egunon. I am Elena Bereciartua. I work at the infectious unit, disease unit in Cruces Hospital. And I thanks very much, Guillermo, for your invitation to participate in this multidisciplinary and international event. And it is a pleasure for me to work with you and carry your delicate patients. Sorry. No, aquí le tengo que dar, un momento. ¿Al negro? Al negro. No, pasará, sí. Because this history began when you and I grew up at Cruces Hospital as internal medicine fellow. You didn't have a long hair, a gray long hair, and I was evidently younger. And we participated in a different kind of events, as you see at the picture. So here you have a happy 70-year woman who has been diagnosed of a solitary pulmonary nodule 6 months ago. Because of suspicion of a lung cancer, she was operated by performing a left superior lobectomy, and the diagnosis has been Wegener disease, and she received high-dose steroids and cyclophosphamide for 4 months. Now she enters the hospital because of dyspnea, fever and cough, and bilateral lung infiltrates. She has already received several antibiotics, and we perform a bronchoalveolar lavage where we obtain Aspergillus terrorus and an elevated viral load of cytomegalovirus. We treat her with voriconazole and valganciclovir, or galsicovir and then valganciclovir, and she evolved correctly. And my questions are, what do you think about? Which is the immunosuppressant condition of this patient? The age, the baseline autoimmune disease, the immunosuppressant drugs, but which of them? Lobectomy, maybe? This is an example to explain that in practical medicine, the relationship between infection and autoimmune disease, it is modulated by very many factors. On the other, the first, the autoimmune disease, the control in the nature and the control of the disease immunity and inflammatory activity. On the other hand, the drugs, current drugs, previous drugs, the duration of the treatment, the combination of different immunosuppressant therapies, and some other factors, individual factors, maybe the age of the patient, other illness and their treatment and interaction between the current status, infection agent exposure in different environments, nosocomial, community, health-related, and the immunosenescence that means that because of the immune activity, permanent immune activity, T-cell capacity may senescence. The Biobadacer registry, the Spanish registry about the adverse events with biologic therapies in rheumatological disease show in the last report in 2018 that among all the adverse events, which is no, sorry, ¿cuál es la luz? Okay. Among the adverse events, 1/3 are caused by infectious disease. You can see that the most important infectious diseases are common infections, as respiratory tract infections, urinary tract infections, etc. And they see also that between the severe adverse events, 1/3 were caused by infectious disease. On the other hand, these BioGeas, or a Spanish study group of biological agents in autoimmune disease, they make a cohort since 2002, about the safety and efficacy of biological treatment in refractory systemic autoimmune disease. And as you can see in this Kaplan-Meier graph, you can see that the cumulative survival rates of patients who are treated with biological treatments who have infections is very much lower than when they haven't infections. What about the infectious agent exposure? At left, you have seen a table with the main infectious disease or process in these patients, and you see that the majority of the serious infections are similar to general population, mostly bacterial infections and less virus and fungi infections. And the most common sites of infection are, as usual, respiratory, urinary tracts, skin and soft tissues, or sepsis. But it is clear that some specific events are more likely to occur and more severe maybe with certain microorganisms in these patients. Taking into account that some of these infections and frequently severe infections may be preventable by screening or vaccination, as we will see later at the end. What about drugs? It matters which drugs, how long, how much dose, and the combination of some of them. You know much better than me that biologic therapies are drugs directed at specific molecular targets for the treatment of different disease, cancer, autoimmune disease, or inflammatory disease. But these targeted sites may be key elements of physiological process controlling immune response, and the blockage of this target may impair immune function and then impair the response, both the innate and adaptive immunity for extracellular and intracellular microorganisms, and the response for acute infection exposure, control of latent infections and chronic infections. Routine and opportunistic infections have been an important complication of these patients, and big effort spent are going to understand the infectious profile of biologic drug classes similar to other immunosuppressed status, like a transplant or chemotherapy or others that nowadays we haven't. The assessment of the infection risk is challenging because the most data has only emerged in post-marketing large observational or population studies, but not in trials that were powered basically for measure efficacy and not safety. But what is an opportunistic infection in the biological setting area? This is a consensus elaborated by a multidisciplinary committee recently. They are trying to define what is an opportunistic infection for patients under biological therapy, and they name an indicator infection. They define the indicator infection as a presence of a pathogen or a manifestation of pathogen which presents indicate a potential or likely alteration in host immunity, because maybe they are common germs, but with a different manifestation in this patient. This list or this definition will help us in the future, we hope, to speak the same language when on studies record the opportunistic infections, and they will be similar, to analyze them and to have a more precise information. Nowadays, we have a long list of biological therapies that you know much better than me, and they are grouped in different risk of infection, as you can see with the red box or yellow box or green box. What about the steroids? Glucocorticoids act upon almost every immune cell type, yes, directly or indirectly suppressing the pro-inflammatory response. And about the risk of infection, there have been very few population-based studies focused on the relationship between the dose, duration, and opportunistic infection. But the risk of infection with these drugs increase immediately with the therapy, is directly dose-related, is usually for common bacteria and less virus and fungi. But there's some opportunistic infections that there are clearly recognized present within these patients. But the threshold dose and treatment duration has not been established, neither for opportunistic infections related to steroids. Here also, observational studies has demonstrated the increase of infections even with low dose of prednisone. But duration has been less defined, and there is a variability by individual and underlying risk of factors. Biologic users may decrease over time the risk associated with steroids because the biologic allow for a decrease in prednisone therapy. This population-based study was performed in Taiwan. I think you know it before me. But it confirmed, they describe lupus diagnosed patients, and they divided into groups, steroid group and non-steroid group. And they determined the hazard ratio of many opportunistic infections. And they demonstrate that the most common opportunistic in steroid group has been herpes zoster and mycobacterial infections. And globally, the cumulative incidence of opportunistic infection has been much higher in the steroid group. In the same study, they analyzed the risk of infection in different doses of steroids. And as you see in this graph, the risk of the cumulative incidence of infection is dose-dependent, and the low patients who receive low steroids are clearly on less risk of infection, and it is maintained for several months. So it's an important question to have in mind. On the other hand, we have your friend hydroxychloroquine that beyond its antiparasitic activity, it has an antibacterial, antifungal, and antiviral effect. And as you has demonstrate, patients taking antimalarials are less likely to suffer major infections. Let's speak about infections now. What should you do if you have a patient with a systemic autoimmune disease and an infection suspicion? Well, firstly, you elaborate an ordered analysis of the situation, identify active problems, elaborate a syndromic approach, consider conditioning factors, think in a differential diagnosis, and design a diagnostic plan. Well, the first question you have in mind is, does the patient need an antibiotic? Why and now? Follow the 5 steps for a correct empiric treatment after some little questions. Which diagnosis do you suspect? You are not sure? Patient is stable? Then you can consider not to begin antibiotics in this moment. But if you see the patient with a serious infection, no, it is not a serious infection. So you can use antibiotics for usual infections. But if the answer is yes, choose an antibiotic effective for almost all microorganisms in this setting. Okay, let's go with the 5 steps. First, which is the cause? Take samples according to the focus and with the correct method for each focus. And don't forget taking blood cultures. 2, choose an antibiotic depending on the suspicion and local guide. You can keep in mind next factors for a systematized decision: gravity, safe, extras. Gravity, about the infection gravity, severe or less severe. S, infection syndrome, think in the focus or apparent focus of infection. Acquirement, these patients are exposed usually to health-related assistance, so keep in mind microorganisms of this environment, or nosocomial or community. F, individual factors. E, local epidemiology of the microorganisms that the microbiology service should publicitate every year, and you have to have them not in mind, but yes, near your history. And extras like a comorbidity, previous infection or colonization, interaction with drugs or allergy, etc. Here you have a table that it can guide you to choose antibiotics for the most important germs according to the focus, but you must guide with your local antibiotic guideline based on the resistant pattern of microorganisms in your center. 4, choose a correct dose and posology of the antibiotic. 4, search and control the focus. 5, duration plan, the antibiotic duration plan. Define an antibiotic duration. If you can't, we're going to stay through 5 seconds. If you can't, rethink every 2 to 3 days. Should you, in 2 to 3 days, you should already have culture results. Don't stay more days. You can decide something. The antibiotic can be stopped according to the result, can be adjusted to microbiology results, or simplify a spectrum, or switch to oral therapy. You try to stop catheter and design a tailored antibiotic program for your patient. And each 2 to 3 days, rethink about the antimicrobial plan. Shorter is better. The shorter is the treatment, the better for the patient and the population, because we will try to decrease the resistance of the microorganisms to antimicrobials. It's true that these recommended durations are not studied for immunosuppressed patients, but think that our patients are not always very immunosuppressed or are not with a severe infection. So we must have in mind that shorter is better if the patient is stable and the focus is controlled. Do not take antibiotics for viral infections, as the rest of the population. And in the last part of my talk, I will say a few words about the main opportunistic infections in this population of patients. Tuberculosis may be a primary infection or a reactivation. The risk for the reactivation may be the immunomediated disease, the immunosuppressive therapies, in particular biologic anti-TNF treatment. The dosage and prednisone put someone on risk. It is not clear. Also, the CDC guideline about the ETL, LTA, latent tuberculosis infection guideline, recommend screening and treatment or suspect above 15 milligrams for a long time, and the prevalence of TB infection in the determined population. Our prevalence is not low in the Basque country and neither in Spain, so we live in a moderate prevalence of TB infection. Remind that pulmonary TB is the most frequent organ, but any extrapulmonary TB may be in these patients and sometimes are oligosymptomatic over the time. The treatment schedule is similar to other patients, but we must stop biologic therapy probably during all the treatment and reduce the steroids dose. About the screening, there are different opinions, but our Basque country recommendation and other authors recommend that patients who are or will be the candidates to biologic therapy and maybe steroids or prednisone for long term, we must do the screening to tuberculosis. We ask for a history of tuberculosis, contact, and scars of previous tuberculosis at the radiology, and we perform the two studies, IGRA analysis and tuberculosis skin test. And if any of them is positive, we have a latent tuberculosis infection, and we will recommend to defer biologic therapy 1 month minimum, and administrate isoniazid for 9 months or an alternative therapy. What about pneumocystis jirovecii pneumonia? It is a rare but potentially fatal opportunistic infection. The outcome of the mortality is described as 30 to 60%, but I think these data are global in immunosuppressed patients, and they are very different for oncomatologic patients or transplanted patients from this autoimmune disease. It presents as an acute interstitial pneumonia with dyspnea, cough, and respiratory insufficiency, and the diagnosis is made by confirmation of pneumocystis jirovecii by PCR at the bronchoalveolar lavage or any other sample, but mainly BAL. The dose and duration of prednisone to trigger a prophylaxis is not established, and in the future we hope we will have a personalized risk assessment to high-risk population and a clear recommendation when determining the duration of prophylaxis for biological therapies that today we haven't with correct data. Cotrimoxazole confers protection for many other bacterial infections, and it can be a good thing for these patients, and like Listeria, Salmonella, Toxoplasma, Nocardia, and many others. About herpes zoster, several large population-based studies have registered a high risk of herpes zoster reactivation infections in these patients, even of steroids treatment and biological treatment. We must consider any form of varicella zoster reactivation as an opportunistic infection, herpes zoster, disseminated herpes zoster, retinitis. Thank you, Dr. Fonollosa, for the picture, pneumonia, and etc. The diagnosis is based on clinical signs and demonstrate the varicella zoster DNA, and the treatment is based on acyclovir, and after we can switch to oral therapy. Now, today we have an attenuated virus vaccine for herpes zoster reactivation and to prevent post-herpetic neuralgia, but it is an attenuated virus and it is contraindicated in immunosuppressed patients. But in 2020, we will have available in Spain a recombinant vaccine that should be administrable in these patients. About aspergillosis, that we are afraid always to this invasive fungi infection. It invades the organism by airway, and it has the ability of invasion of blood vessels, producing tissue infections. Based on the degree of invasion and the control of the patient's immunity, it is able to present different kind of invasive or less invasive disease. when we have an invasive aspergillosis, the symptoms are not specific and remarkable symptoms as fever, cold, or discomfort. And because of this, it is one of the most common diagnostic errors in necropsias. Prolonged and high-dose steroids received patients and other immunosuppressants are a population at risk, and we must suspect it when the patients are not going correctly and remains febrile despite a broad-spectrum antibacterial treatment. And early diagnosis is a challenge. You must push to other specialists to perform tomography early, bronchoalveolar lavage early, and to the microbiologist to report the results early to initiate the treatment early also. And the treatment duration with voriconazole or amphotericin, maybe the duration depends on clinical response and the immune reconstitution, and it is not defined. The last part, preventing infection before to the beginning of the future treatment with high-dose steroids or maybe high-dose or biologic therapies, we will perform a systematic serological screening in the patient to the knowledge of disease that are preventable or to treat, as you see in this a bit usual list. About the screening of hepatitis B, we will perform a screening based on serology and viremia, and we would recommend prophylaxis when the viremia is high viremia, or even with anticorp positive. It depends on the disease and the treatment they are going to receive. And about vaccination, remind that the vaccine calendar must be updated at least 4 weeks before the starting of immunosuppressive therapy. The attenuated vaccines are contraindicated, so we must give them 1 month before or 3 months or more or later after stop the treatment. The inactivated vaccines you must give to the patient then, but before the immunosuppressant therapy. And there are some points with have no clear response during the treatment because they can have no optimal immune response, or sometimes we have no very clear which is the time for the vaccine in some patients, and request for analysis for vaccine response control. Our local vaccine guideline give us specific recommendations that are in this list, mainly pneumococcal vaccine and annual influenza vaccine, and then the others in particular situation. Don't forget chickenpox. In every people have never had the illness, never had received the vaccine, and have a negative serology. And about the Hpv vaccine, here the recommendation is for women up to 26 years who are going to receive azathioprine and, under parentheses, other immunosuppressive, and there has been conizated or are going to be conizated. But the Spanish guideline in the bottom, or in the top, here, declare that these patients, immunosuppressed patients, can benefit regardless of the age and sex, and in particular women affected with lupus, but this is not for our region. Conclusions: infections and autoimmune disease frequently walk hand in hand. In general, we would suspect common infections. Follow the 5 steps for a correct antibiotic setup. Don't forget doing a suitable and on-time screening of preventable disease, and reduce dose of glucocorticoids. And if you don't see it clearly, add an infectologist to your multidisciplinary team. Thank you very much.
you.